Okay, so this time we're looking at more dysfunctions of the heart. These are a little bit more serious, and well, they're all serious, I guess, but we're looking at the second part of our heart required readings. So, one of the big things I wanted to focus on in this one is when it talks about dysrhythmias and kind of the electrical pathway of the heart. So while you have a mechanical part where the cells are actually contracting, it's the electrical component of the heart that makes the mechanical work, right? So, and these two can obviously influence each other. You see. So just looking at this, this is the typical conduction route of the heart. When they mention the SA node, that's right here, that's your sinoatrial node, because it sits in the atria, the right atria specifically, or right atrium. But that's where your primary pacemaker is. So like the heart's own pacemaker. That's going to send messages throughout the atria, both sides, and then it's going to conduct down to the AV node or the atrioventricular node because it sits right kind of in this tissue area between the atriums and the ventricles. Then it goes down what's called the bundle of His. HIS, yes, His. I have no idea why it's called that. But if you've ever heard of a bundle branch block, this is the area that it's talking about. And then as it gets down to the ventricles, it goes out into the Purkinje fibers. And each one of these actually has its own separate heart rate, which sounds kind of weird, but basically, so like your Purkinje fibers, those are going to beat at about 15 to 20 beats per minute. Then your bundle of His is going to be about 40 to 60. Your AV node is about 60 to 100, and then your SA node is 100 to 120. So what's kind of unique about the heart is with this conduction pathway, obviously, your SA node is going to send that initial pulse, and then the AV node catches it and slows it down and then sends it to the rest of the heart. As the heart starts to have issues or kind of give out and die, at least on the electrical side, that's where you could start seeing some bradycardia, and then definite EKG changes. I don't want to get into EKGs too much because that's like opening Pandora's box. But if you want to learn more about EKGs, just let me know because they're really not too hard whenever they're broken down. Just know with every single one of these diseases that we talk about, there will be EKG changes. And I do have actually a few EKG changes just to show kind of what's going on. So they specifically point out your tachycardia, which is anything greater than 100 beats per minute, mentions that your sympathetic nervous system releases that epinephrine. Epinephrine is very important in medicine. It does a lot of things, but mostly what it does is it works on your beta cells. in the heart, which is really like, usually I don't care what kind of cells, right? But this one actually does matter because epinephrine specifically works on the beta receptors, which are going to stimulate both the increase of heart rate and the increase of blood pressure. This becomes important in shock, which they kind of talk about in the end. It's not part of the test, but I think it's interesting. And I also know it pretty well as a paramedic. But whenever a patient comes in with hypovolemia due to some kind of shock, other than like they're bleeding, obviously if they're bleeding, give them blood. But so for cardiovascular shock, all those kind of things, as a paramedic, I get to decide which drug to use. And so we have things called pressors, which increase your blood pressure, hopefully. And one of the two main ones are epinephrine and norepinephrine, both naturally produced by the body. Epinephrine works with beta cells. So think B as in your second one. So it's two effects, one on the heart rate, one on blood pressure. So if I have a patient who's pretty stable on their heart rate, but their blood pressure is crap, I'm actually going to use norepinephrine, which works on alpha cells, or one thing, and that is blood pressure. But that's kind of how I remember what each receptor does. The other thing they mention is your electrolyte changes, such as hyperkalemia, which is high potassium. Potassium is definitely going to be your number one issue when it comes to electrolyte imbalances in the heart. The three main chemicals that make the heart pump are potassium, sodium, and I'm blanking on the third one. And calcium. There we go. Sorry, I had to like see it in my head. Each one of these will cause EKG changes, and will cause lots of issues if it gets too far outside of the range that is normal. You're going to see kalemia issues with especially your diabetics. Diabetics, your dialysis patients, and your heart failure patients. And that's all kind of due to the treatments that they're on can sometimes spill or add too much potassium. But we'll get to that. So, and then it talks about just glitches, or basically like something happens, either illness or like family history is a big part of anything heart related. So any sort of you can get some really weird things in the heart, like conductivity pathway, where they're called reentry loops. You can get that where it's basically just extra tissue that creates a loop of electricity. But those are the big three that they focus on, is the epinephrine, hyperkalemia, and then just tissue glitches. In bradycardia, anything less than 60 beats a minute, which I will also say, if you have someone who is younger and works out, is very active, or even like sometimes I've seen it in older populations where they just naturally are bradycardic in like the 50s. Like they just sit chilling in the 50s, almost 40s. So don't always look at that and freak out, because I mean, bradycardia is a lot scarier to me than tachycardia, just because you don't have as much wiggle room before it gets to zero. But some causes of abnormal bradycardia would be your your parasympathetic nervous system secreting acetylcholine. That's going to have a opposite reaction to cardiomyocytes than it would to regular muscle. For regular muscle, acetylcholine actually stimulates it and causes action, whereas with cardiomyocytes, it actually decreases the action potential and slows the heartbeat. Then talking about hypokalemia, again, it looks like they're pretty fixed on potassium, which is understandable. So just remember that your potassium correlates with the heart rate. So like hyperkalemia causes hyper heart rate, tachycardia. I say hyper heart rate because tachycardia does not seem, it just doesn't flow well. But and then hypokalemia causes a slow heart rate or hypo. One big thing it mentions here that it doesn't mention in anywhere else is ischemia from a right coronary artery narrowing or blockage. So then they use RCA and they use others elsewhere, and they don't explain it at all, which is really, really hard. So your RCA, your right coronary artery, is the actual artery feeding the tissue itself. That's where we get into like heart attacks. So stop sharing this one and then look at, okay, this is our normal one. So this is your right coronary artery, and what this is called a coronary angiograph. It's done in the cardiac catheter lab, which is, if you ever get the chance to shadow in there, like please take it. It was the most helpful thing. Like seeing something about seeing it all being perfused is really cool and like just makes things click. So on your right side, this is your right coronary artery. You can kind of see the outline of the heart, but know that it starts at the very top and goes around the right side, but also comes all the way up to the apex of the heart or the tip of the ventricles. It feeds a lot of the heart. So you can see how large the artery is. Oh, am I not sharing this? Okay, let me retry that. Sorry. Thank you for letting me know. Okay, is it showing? Hopefully. Okay, so this is what I was talking about with the cath lab. So this is the RCA, this whole thing. And what they do basically is they go in, it's kind of crazy. They use this wire to go all the way up from either your radial artery in your arm or your femoral artery in your legs. They use this wire. You can kind of see the wire. It does, some of them have like a little loop on the end. Some of them are more straight, but this is, the straight thing is the wire. So they feed this wire up, and then it goes into going through the artery system. They get to the coronary arteries, and then they shoot contrast, which is like the same contrast used for like an MRI or a CT. And basically it's just going to darken the region, like darken where the contrast is going, so it shows the flow of the heart. So here, this is the right side of the heart, how it gets perfusion, and then so we're probably looking at the heart from the side in this picture. Here, we're looking kind of at the top. This is kind of the outline of the heart. This comes down, this is your left main coronary artery, this little section here, and then it branches off, and you have your LAD, your left anterior descending, and your, what's your diagonal? I can't remember. But either way, like, obviously you have three large arteries, and so any occlusion to any of these arteries is bad, but especially right here at this little, like, where it breaks off into two, whenever you get a clot here, that is called a widowmaker clot, or a widowmaker heart attack, because obviously it's taking away perfusion to most of the heart, and it used to be that most people didn't survive that. A lot of things that I've noticed in here with cardiology are very, very, very outdated. And I say that in the nicest way, but seriously, like, a lot of things that we used to consider critical about the heart or normal about the heart are no longer followed like that. And I'll kind of explain that as we go. But so these are your coronary arteries. And so they're saying that anytime that you have a clot in your RCA, you're more likely to have a dysrhythmia. And that is simply because it starts at the top of the right ventricle or right atrium and goes down, and your SA node is right there. So if it's blocked, you're probably going to start having some sort of dysrhythmia because it's not getting perfused. So that's kind of the idea when they talk about the RCA narrowing or blockage. So it kind of shows like why the conductivity also goes in with the actual mechanical. And then of course the whole glitches in the SA node and AV node and all that stuff. Then we get into dysrhythmias, which, by the way, like, you have normal sinus rhythm, and then you have dysrhythmias. Like tachycardia and bradycardia are considered arrhythmias or dysrhythmias. Those are interchangeable words. So one of the big ones is atrial fibrillation. It is a very popular issue that everyone has. So basically, stop sharing this one and pull up the. Okay, so what's going on with atrial fibrillation? We have our normal conductivity over here, everything that I just kind of explained. With AFib, what's really interesting is basically what a pacemaker, like the SA node, is a concentrated, like, bundle of like electrical cells. They are cells that create electricity. That's their job, and it's just like this little bundle of cells, almost like a tumor, which sounds really weird, but that's kind of the best way I can describe it. So what's weird is you can start growing these little bundles of electrical cells kind of all over your atrium, and really where they're starting to find they originate from is your pulmonary arteries and veins, which they don't understand why. They've also recently noticed that if you have a person with AFib that gets a heart transplant and the nerve is cut. When they put the new heart in, they don't have AFib. But and I can't remember what specific nerve, but basically from talking to the doctors that I have, no one really understands why AFib is a thing, but it is a thing, and it's very common, and it can be very, very deadly if left untreated. So basically, you get these little bundles of cells that shoot off electricity, and so instead of having one normal rhythm where that SA node sends off that pulse and it goes through the normal pathways, you have like little stimulations all over, like just all over. So instead of trying to, your heart obviously, it wants to follow that conduction pattern. So when you have a lot of different crazy signals coming from everywhere, the atrium's trying to keep up, but it's kind of like getting hit with a shotgun blast, like, because every time like all these pellets fly out, and they're not trying to respond to just the main shot, but also the pellets. I don't know if that was a helpful example, but so the atria end up shaking instead of pumping, which sounds really weird, but that's what the whole fibrillation part is the idea of it fibrillates instead of contracts. Because again, the atria, the muscle, all of that is trying to react to that stimulus. So I don't want to get into, like I said, too much, but if you're looking at an EKG, this would be like you can see like this looks pretty steady, pretty normal. The P wave in EKGs represents atrial depolarization, or basically the SA node is firing off that initial shot. One thing you won't see in AFib, which is above, is a clear P wave, because there's so many different conductions going on. You also will notice that these peaks, this is your QRS complex, and that represents ventricular depolarization. So basically everything going down the bundle of his and out to the Purkinje fibers. That's going to be a pretty steady normal rate, whereas above you can see it's just kind of all over the place, and that's because there's no clear SA node driving anymore. It's kind of just like all these random like signals, and so it's just kind of like grabbing one and grabbing another. And so with atrial fibrillation, even if the patient doesn't know they have it, but you put on a pulse ox, and all of a sudden the pulse ox is going from like one extreme to the other, and is not, it's just not keeping the same pulse, and you're like, what is wrong with my machine? It's more likely that they have atrial fibrillation. You can also feel it when you check their pulse, because their pulse is just going to kind of be like, it may be normal for a few beats, and then it kind of stops, and then it kind of varies, because it's literally just trying to catch whatever it can. This can become a huge issue when something called RVR, or it's rapid ventricular response. So I could not think of the rapid. So basically, the ventricles try to catch up with the signals that are being sent out. But again, remember, these are not regulated. These are random cells. And so you can get the heart rate up very high. The highest I have seen sustained is 240 beats per minute. She was not all there. That was a very scary moment as a paramedic. and thankfully the medicine that we gave worked and slowed everything down. But that was caused, she actually had AFib, was treating it properly. She was very, very sick, became septic, and the sepsis itself triggered a kind of a bad reaction in the heart and threw off everything, and her AFib was no longer stable. So no, that's one of your big ones that can change with sepsis is the electrical pattern of the heart. I've seen it with sepsis a ton, and I've seen it with DKA, diabetic ketoacidosis. So anything that's going to throw off chemical wise in the body is definitely going to start affecting your heart. And if they already have the condition, it's going to make it worse. I also really want to point out, it mentions that it's fairly common amongst elderly due to heart disease or simple aging, 3% of adult population. That is not correct. I looked it up. As of 2024, and really it's as of 2019, but what they're saying as of 2024 is that it's 4.5 to 7% of adults have AFib, with 1 in 22 1 in 22 adults having AFib in their life. And that's per the National Institute of Health. So like, I'm not just making it up. It can definitely happen because of like heart failure and that kind of stuff, but it can also just happen for no reason. And again, they don't really know why. They're still studying that quite a bit. So AFib is a kind of weird one, but it's one that you will see all the time. And it goes into the two, I don't know, what did it say, two types, two categories? But basically the two different things that can happen is there's a small but sometimes significant decrease in your cardiac output. That's because they're quivering, right? They're not squeezing. So all the extra blood that you get from the atria, whenever it squeezes into the ventricle, you're not getting that. It's just it's quivering. And then because of that too, if there's nothing that actually squeezes, the blood just sits there, right? And specifically in your left atria, there is a little portion of it. It's the left atrial appendage is what it's called. And it's just this little weird like pouch that comes off of the left atrium, but it's also where a lot of blood collects if you have AFib, or clotting issues in general. Sometimes you'll get that one signal that actually comes from the SA and makes the ventricle or the atria have a good contraction. That's terrible because then all the clots that are kind of built up in that little appendage, just where like 90% of clots come from, with AFib, is that left atrial appendage. You get what's called a clot shower because you literally just sent out a bunch of clots into your circulatory system, and since it's on the left side, it's your artery, your aorta, so it can cause, it literally can cause heart attacks, strokes, or CVAs. We don't like the word stroke. CVAs, and then it can become bigger and turn into a DVT, a PE as it comes around in the circulatory system. So that's really where AFib becomes really dangerous, and we have to be careful. The biggest way we treat that is going to be, you're going to see them on blood thinners. Usually Xarelto is the go-to. It used to be warfarin or Coumadin, but it's very rare to see that nowadays. Like literally from, I think it was like within a 5-year span, the amount of people on warfarin in 2012 to 2017 was 98% to 17%. Like that's how much it decreased because we started getting these new medications in that were better for the patient, less side effects, and you didn't have to do blood work all the time, but you will occasionally see a patient on warfarin. They're usually much, much older. Then they talk about ventricular fibrillation. There are two out of all the rhythms that there are, and there are many, many heart rhythms, there are only two that you can shock. And ventricular fibrillation is the number one thing you shock. When you see it on the screen, it's like the first thing you should be doing is slapping the stickers or paddle. They still call them paddles, but they're not paddles. Putting the stickers on and shocking them. Actually, like we're always taught, and we always teach the public in EMS, the first two things that matter the most in getting someone back from cardiac arrest is early good CPR and early defibrillation. Because when the heart goes into VFib, you only have about 3 to 4 minutes before it is done. Like basically, like the heart is just done. But if you can get in, interrupt that signal, and I mean, basically defibrillation is it's literally turning it off and on again. like it kind of like smacks the heart with electricity and it stops for a second, and then we hope that it goes back into that normal rhythm. A EKG of that is going to be, there we go, is going to be this. It looks chaotic, it looks bad. It is, because instead of the fibrillation being in the atria, it's in the ventricles. So the ventricles are just shaking, and that's really bad. It's obviously unorganized. This one I'm actually pretty sure shows there's different types of VFib, but no matter what, the answer to all types of VFib is electricity, and a lot of it. To give you a reference, we usually shock at 360, and then a tase 360 joules. A taser is 0.64 joules, just to give you an idea. So a lot of electricity going into the heart to try to stop that and hopefully get it to do what it's supposed to do again. So they just have a really small section about that, but the whole thing is, if you don't, there is no cardiac output happening. Like it is like legally in VFib, you are legally dead. You are dead. You can be brought back, but you are still dead because you do not have a heartbeat. Then it talks about stroke volume changes that may pathologically affect cardiac output. I feel like sorry, I saw something in the chat. Finding AEDs and sharing with the communities. Yes, so this is a very good point, very interesting. So AEDs, automated external defibrillators, they kind of look and act exactly like what we have as paramedics. The only thing that differs is the automated part. So literally, like, the machine will read and tell you if they need to be shocked or not. My machine doesn't do that. I'm the person that does that. I read the rhythm and decide if the person should be shocked. So AEDs are really important. Like I was saying, the main two things when someone goes down is good CPR, immediate defibrillation. That works great if someone's in my truck and dies in front of me. I can do that really fast, but obviously most of your out of hospital heart attacks and cardiac arrests are not going to be with a paramedic. So yes, they have started buying cities will do it. I know where I grew up, which was North Richland Hills, if you're familiar with the DFW area, it's kind of like Fort Worth area there, or if you've ever heard of NRH2O, that's where that is. So while the whole story behind that, the reason I bring it up is there was a girl, NRH2O is a water park, and there was a girl named Sarah who had basically an undetected dysrhythmia. And while she was waiting in line to go on one of the rides, something happened, the arrhythmia kicked in, and she went into VFib. There were no AEDs at the water park. This was like early 2000s. AEDs just weren't really popular. And even if you had them, not a lot of people were trained on how to use them, which is really sad because they're like super easy to use. So she ended up losing her life, unfortunately. And her mother created this foundation that they would do like a 5K every year. They would do a bunch of fundraising, and all of that went into buying AEDs for the community and putting them in the community, and then also teaching you how to use them. What's nice about AEDs is they tell you what to do as soon as you open them. So it will tell you, I think most of us have probably done CPR training, but it's always with CPR training that we do AED training. Just make sure you're not touching the patient when you hit that button, or anyone else, because you will get shocked, and it can either mess up your heart or it hurts really bad. That's kind of my thing. And then yes, there are, within the last year or two, they have been selling, Philips specifically has been selling private AEDs. So like AEDs you can buy and keep on your person in your house. These are great for people who are, they have coronary artery disease, they have these perfusion issues, these cardiac issues, and they're at a higher risk of what's called sudden cardiac death, or basically you go into this arrhythmia. So AEDs are really cool. The way that they work, what they do for people. There's some pretty cool ones coming out. Like I was at the American Airlines Center the other day for a Stars hockey game, and I was looking at the AED because it said Life Pack, and that's the monitors that we use in EMS are called Life Packs. And so I researched it. Well, so this AED, super cool. As soon as you open it and start engaging, pulling the pads out, putting the pads on, not only does it start reading the heart rate and trying to figure out, do we shock, do we not shock? It also has a built-in thing that will tell you while you're doing compressions how well you're doing compressions. And the coolest thing to me is it immediately transmits to Dallas Fire Department. The responding ambulance is going to automatically transmit to their monitors, and they're going to see when bystander CPR was started, when pads were placed, when the first shock happened, if it did, all that kind of stuff. So we're getting really, really advanced with our cardiac science. And that's why I kind of say, things like coronary artery disease, heart failure, AFib, all that kind of stuff. It used to be a death sentence, and it's really not anymore. There's so many ways to manage it if you catch it early. That's like the biggest thing. and this is coming from someone who has a long family history of really bad heart failure, everything. My Mimi died at 57. Her dad died at 30. I'm still pretty sure that one was rheumatic heart failure, but I don't actually know because it was back in the day and they just didn't do autopsies. They didn't do anything to study it. So, you know, my mom and I get checked pretty frequently with how our heart is doing because of that. So going back into stroke volume, if you haven't figured it out, pump action, volume, and resistance, or contractility, preload, afterload, like know those inside and out. It does also keep mentioning the word inotrope or inotropic. That literally just means things that how hard the ventricles can contract. So if it's saying negative inotrope changes, it's talking about things that will make the heart not be able to pump as well. Positive inotropes are going to increase that push. I always think of iron with inotrope because it almost is iron with the first three letters. It's missing the R, but like if you're pumping iron goes to muscles to make them stronger, all that kind of stuff. So just, I'm not going to go into that too much just because it goes over it so many times this whole time. So the biggest thing that can lead to heart failure is that resistance or those blood pressure issues. And then it can also go the other way with a decreased afterload seen with shock, any type of shock. So then going into coronary artery disease, basically coronary artery disease is where plaque has formed in the veins. That plaque is going to be, well, now they're starting to find this was released in October by the AHA, but they found that plaque is actually a biofilm, which is like a living organism thing, like almost like a gel, and it holds a lot of different types of bacteria, and then it helps the bacteria communicate, it blocks antibiotics, it does like all this stuff. So the same plaque that's on our teeth is the same plaque that's in our vessels. And they were able to finally confirm that by scraping the plaque out of people who had died of sudden cardiac arrest or sudden cardiac death, and comparing it to the plaque on their teeth, and found that it was the same exact composition. So know that plaque does not just sit there, because I always thought it just kind of like it was there. It's lipids. It is a very alive thing, and they don't really know what to do with that, which is great. But that kind of lipids will kind of stick to that, and obviously lipids are the foundation for a lot of building blocks. So your cholesterols will definitely attribute to the growth of that plaque. It also mentions the amino acids that lead to oxidative damage, which is similar to the idea of free radicals. Basically, unstable oxygen molecules can cause issues, damage. And so that's why we focus so much on antioxidants and all those things, because it can basically bind to that oxygen and keep it from damaging tissue. So it mentions that. It mentions that it's been correlated with the elevated serum C-reactive protein, which, if you remember from last test, is all secondary inflammatory cascade, and basically like is almost like a constant state of SIRS. But don't necessarily, I've never seen them test, like cardiologists test for serum levels of homocysteine or CRP for heart disease. So like they're just kind of giving you an idea of risk factors. It's also going to be the exact same as your hypertension and atherosclerosis, where, you know, poor diet, poor sedentary lifestyle, high fat diet, or none of that, and just really crappy genetics. Those are all risk factors of CAD. Let's see what it. So there's also a good thing to mention. Infarction is when the clot starts blocking blood flow. Infarction leads to ischemia, which is death of the tissue due to lack of oxygen. That becomes important terminology in this, because infarction can be reversed, ischemia cannot. And they try to get into that, but definitely don't do a great job of it. But we'll get there. So next page, page 6, at the top, they talk about it being a spectrum with your mild ischemia to maximal ischemia, meaning the damage done to the cells can be reversed, or it's dead. It's irreversible. So there's obviously heart attack, myocardial infarction. They're the same thing. There's two different types, which really, they're not two different types. So with mild ischemia is what I would call a STEMI or ST elevation myocardial infarction, meaning you'll see it on your EKG. Someone posted about it in the group meet, super helpful. That's what a STEMI looks like on your EKG. Sometimes it's not as clear as that, but usually you can look at them and be like, oh my gosh, they're dying. So the reason that we kind of freak out about the STEMI and like call in STEMI alerts and all these kind of things is, if we can get the patient to the hospital in time and we have our cath lab on standby, they can go in and basically suck the clot out and put a stent in and reperfuse everything beyond that, which is really cool. So you can literally have a heart attack and have no damage from it if we're fast enough. But people have to call right when they get chest pain, and they don't always do that. So it talks, and then it starts going into the common symptom of CAD is angina, or angina is another way you may hear it be said. Angina is similar to having a heart attack, because basically it's, you know, there's a clot somewhere in the vessels, you don't know where, and you increase activity to the point that there's more oxygen demand, but because of that narrowing, there's not enough blood being sent out to be received. So then you start getting chest pain because you're not perfusing your heart enough. Versus like a MI is where that narrowing becomes 100% occluded or like 98% occluded and you're not getting perfusion. what's cool, and it mentions this with stable angina. So if you have a clot developing sometimes in multiple places, it mentions that it actually activates arteriogenesis, or the creation of arteries, and these are called collaterals. So, and I try to think of it as like collateral damage. It's trying to prevent collateral damage. And so the heart will grow around, it's like a natural bypass, like a natural coronary artery bypass graft, cabbage. If you hear that term, they're not talking about lettuce, they're talking about a bypass surgery. So these are what collaterals are. So you see the RCA is not that strong. It's got some blockage in there, and you can tell simply because it's kind of lighter and smaller than the other ones. So what's happened is from your left main and diag, it's grown around, because you're looking at all of, like when you shoot contrast, it's looking at all of the vessels. So keep in mind, this is not one specific area. It starts around the vessels and goes all the way around. So it's starting to grow around to the right side of the heart where it's not getting as much perfusion. This is really cool because it literally is your body saving itself. And I have seen in the cath lab where they shoot contrast and nothing lights up in where the artery should be. And you see all the collaterals that have grown towards the artery to basically make up for what it's lacking. I don't know if it does this anywhere else. I mean, I can see it being in like the brain. I know the lungs don't do it, but so it's kind of unique to the heart, but just kind of really cool. So that's the idea of collaterals, is that they're growing, they're not existent originally, like you're not born with them. You grow them from the arteries that are working. Then looking at, so symptomatic versus asymptomatic angina is stable angina. It also says that unstable angina becomes acute coronary syndrome, kind of. For testing purposes, it does. Just know that a lot of times you'll hear stable versus unstable angina versus ACS. And then also on the other side, I mentioned the STEMI. There's also an NSTEMI, which is a non-ST elevation myocardial infarction. This pretty much means like they've had a heart attack. With a heart attack, you will always have ST elevation at some point, whether you capture it on the EKG or not. NSTEMIs just mean that the heart has gotten over the stress that's been exerted on the heart for that event. So with a STEMI, if you pull a troponin immediately, remember troponin is what measures how bad that heart attack was. If you pull one immediately, you may not have very high troponin because those cells aren't dead yet. And if we can get them reperfused, you shouldn't really have an elevated troponin. But with an NSTEMI, you're going to see an elevated troponin for sure. Because at this point, we didn't get to the clot fast enough. The heart didn't get perfused well enough, and those cells died. So that's kind of the difference between the two. If you ever hear those terms, know that it has to do with EKG changes, but it is also reversible versus irreversible. And even now they're starting to find the infarction or the irreversible. They're doing cardiac rehab which is like physical therapy, but like for cardiology. And they're finding that even the cells that they thought were dead are not completely dead, and like they've been able to see restoration of blood flow to some of the tissue even after when they've gone into cardiac therapy. So that's really interesting because that is not something that people used to do. So yeah, I mean, there's just some really cool stuff about the heart. It's like cardiology is my favorite thing because there are so many cool things that the heart does for itself and that we are able to do. So a big thing with angina. So like I said, you start doing a lot, like the one we always use, you're mowing your lawn and your chest starts tightening up because you're exerting, and then you need more oxygen and you're not getting that oxygen. But then either you stop and breathe and get oxygen, and it takes a few minutes, but then your chest stops hurting, or you can take nitroglycerin. That is one of the big ones that are used. Nitroglycerin is what is called a potent vasodilator. And I say potent because it is not like your other blood pressure medicines, like blood pressure medicines that are for stability and continuous use. They bring it down slowly and it stays there, and you have to take it all the time. This one, if you take it, it drops your blood pressure fast. Actually, one of the side effects can be headache because of the dramatic change in perfusion. So the idea behind that is opening up that vessel, even though there's a clog there. If we can dilate it, we might be able to get some more blood through. It's also, they mentioned that it is for increasing the ability for things to go in and out, the lumen capability. I can't remember what they called that, but something about the lumen. So that is a big one. It also it decreases the afterload, so the pressure that the heart has to overcome to get blood through, it decreases that as well. That becomes very important when we get into heart failure. But just know that no one is really on like continuous nitroglycerin. They're going to have other things like ACE inhibitors for that. But nitroglycerin is one of your rescue meds. So they have it as a under the tongue dissolvable pill. I personally, in my experience, those do not work because their body is basically like in fight or flight, and so their mouth gets really dry, and then the tablet can't dissolve, it doesn't absorb. I'm a big fan of the patch. So it's like nitroglycerin gel, and you like put it, it's literally measured in inches. So you generally put like an inch of gel on this paper, and then you put it on their chest, and it opens everything up. The only issue, and the whole reason I bring up nitroglycerin specifically, is when you're getting it out of the Pyxis or putting it on someone, or you're taking it, maybe they have a patch on, but you're taking it off because you need to put pads on it and defibrillate them. Don't touch it. If it's in the pill, if it's in the gel, if it's whatever it is, don't touch it, because it is highly permeable with your skin, and then you will have hypotension. They used to pull jokes on paramedics and new paramedics where they would like put some of the gel on a handle of the ambulance or something like that, and then they would pass out, and it was all fun and games. This was like in the 70s when EMS first started, and then like, you know, OSHA happened and they were like, what are you doing? That is so not safe. So just know that it is a very potent vasodilator. It's going to help a lot, or it's going to do nothing. That's kind of how medicine is. If it is doing nothing for them, that's probably really bad. Or if you take their blood pressure and it's still high and they've popped 3 of those, yeah, you're going to have to go to something else. So just kind of keep that in mind with nitroglycerin. It also mentions aspirin acting as an anti-inflammatory. So this one's pretty controversial these days. Pretty much what I've heard is that if your patient is already on aspirin, just have them keep taking it. Yes, nitro is as needed. Sorry, I just saw that in the chat. Nitro is anytime you get that chest tightness, that chest pain, or they're having that, you take their blood pressure, it's like sky high. It's rapid. So we like that over things like ACE inhibitors and normal beta blockers, all those kind of things. Those take a little bit longer to work fully, whereas nitro is fast and hard. So with aspirin, so if they're already on it, leave them on it. But if they're not on it, don't put them on it, because they're really finding that aspirin does not do that much for both acute coronary syndrome and myocardial infarction and cerebrovascular accidents or strokes. So usually they would take 81 milligrams a day. And then if something happened where they did have a STEMI or they had acute coronary syndrome where they're getting that chest pain, we would make them take 325 and you have to chew it, which is like the worst thing ever. So that's great for people with heart disorders. Oh, I always felt so bad making people chew that stuff. The whole idea was that it doesn't act as a blood thinner. It keeps the cells from sticking to each other. So like it doesn't stop this, like it doesn't reduce the number of thrombocytes produced. It doesn't do any of that. It just keeps them from like the clot from getting more blood to stick to it. That's really all it does. Is it makes the clot like slippery. Less clotting, less chance of worsening, right? So that's why we would give it both regularly and acutely. What I was taught was anytime someone has chest pain, if they don't have ST elevation, it's considered acute coronary syndrome. I had never seen acute coronary syndrome as unstable angina, just because angina doesn't cause issues. But like if this is an old heart attack that's causing issues now, the block is still there and everything, then you don't know that. So it's acute coronary syndrome. Or they could be having what's called a silent heart attack, where there is active blockage, active damage going on, and it's just not picked up on the EKG. Really with EKGs, when we do 12 leads, which are considered diagnostic leads, it shoots from 12 different views, basically. But it's really only looking at the front part of the heart. It doesn't really look at the back. So we've started adding on to like 15 lead EKGs where you just kind of move some stuff to the back. But really you're only looking at the front part of the heart. So sometimes a silent heart attack can be the back side of the heart. So there is active damage going on that we can stop, but it doesn't show up on the EKG. And that's where we kind of see acute coronary syndrome. Yes, it will be uploaded, and it's actually recording this time because I didn't get it to record last time. So I will upload it after we're done. So acute coronary syndrome turns into either unstable angina or into an active MI. So basically, one is a rapid trip to the cath lab and one is a slow trip to the cath lab. It mentions a substantial change in pain, such as a patient who usually gets rid of pain with one nitroglycerin can only feel relief when there's 3 nitroglycerin tablets. Honestly, that's not really completely accurate. Again, it doesn't all, like, nitroglycerin, people don't always respond to them, and sometimes it just doesn't work like that. Sometimes it does. I'm not saying it doesn't. But it also mentions that an EKG usually shows acute ischemic changes with unstable angina, and that is not true. They're getting that mixed up with a myocardial infarction. You can see old damage, so old MIs that did cause damage. You can actually see those changes in the EKG, but they're in different places. So usually with acute coronary syndrome, maybe it's not ST elevation, but I see some depression somewhere or something like that that makes me think, okay, well, maybe this person has had a heart attack and they're having kind of the effects of that. So just remember, like, unstable angina is considered like chest pain that has gotten worse and is not getting better, and there's no active clot going on that we can see. Myocardial infarction is where it is, we can see it in the EKG, we can go in with the cath lab and we can suck that boogie out and open the artery with a stent. It's also an acute, like truly acute, like not just from blockage from buildup, but like you're sitting there and fine, and then the next second you're like sometimes even dead, but like you're in extreme pain. That's because the plaque has ruptured and starts forming a thrombus within the artery, starts bleeding. So then you get an acute clot in your heart, which is terrifying and not fun. But it is reversible if we can get them in and pull out the clot. When I say, let me show you what I mean when I say pull out the clot. So, did it go? There it is. So also it says in the FYI not on test, there's like so many things wrong with it that makes me want to scream, and I have to mention it. Acute hospital interventions or pre-hospital interventions, it used to be something called MONA, morphine, oxygen, nitroglycerin, aspirin. It is not that way anymore. So like they don't do a ton of IV heparin either. That's going to be used in the cath lab, but like heparin can also cause thrombocytopenia. So they're very careful. And some people also don't respond to heparin, which is weird because it's natural. But if their O2 is normal, we're not going to give them more oxygen because it can actually shrink your brain if you're over oxygenated. Nitroglycerin, if they're having the chest pain, we will give it. Some doctors will not give it if it's in certain areas of the heart because it can basically put them into cardiac shock. Morphine has been associated with higher levels of clotting and slower or less oxygen reperfusion when that clot is pulled out. So doctors, I still see them give it all the time, but you will never see a good new medic give morphine for chest pain. It will always be fentanyl. Honestly, we just don't use morphine because it can cause, like, it, people don't respond well to it. It doesn't work that great, and it can drop blood pressure and breathing so fast that if there's something going on that we can't see, since we don't really have, like diagnostic imaging, like if there's something going on and we give them the morphine, it can drop them so fast. And fentanyl doesn't really do that at all. And a lot of people are starting to get an allergy to morphine where they're not getting it to fentanyl because morphine is natural from the poppy seed plant, from poppy flowers, and then fentanyl is a synthetic opioid. So they can kind of alter it to not be as like reactive, I guess is the best word. So just know, like, EMS gives a ton of fentanyl, and it's simply because it's like way safer than morphine, which is actually super ironic because obviously fentanyl is a huge issue in the US right now with overdoses and drug addiction. But we use micrograms versus grams. So just to give you an idea on that one. It also mentions the percutaneous transluminal coronary angioplasty. I have never heard that used. So it's been out of use for a while. We call these PCIs, or percutaneous incidences. And it literally just means like we're going through the tissue of the artery, sending that wire up and shooting contrast, and then doing something to help perfusion if it's needed, whether it's ballooning or stenting. Stenting actually leaves some wire mesh that opens everything. So in A, you can see here's your wire, and they shoot contrast for the coronary arteries, and nothing. There's a blockage here, there's a blockage here, and there's a blockage here. The worst thing to see is nothing like that. So then they'll go in and they'll find where the clot is, open it up with either, if it's a thrombus, they'll suck it out and then use a stent to open it up. If it's just the plaque itself, they'll just push through it and open it up with the stent. So then you can see what should be right here becomes B, your right coronary artery, and then they're able to reperfuse some of that left left anterior descending, your LAD, and then a little bit of that diag. And what's interesting is right here, you see that little pinch where it goes off? That little pinch is actually what you're looking for. That's occlusion. You can see it better in D. So there is some plaque right there. You can kind of see it down here too. It just means that that's where the occlusion is. If we're in the cath lab, not for an MI purpose, just because they failed their stress test is one of like the biggest reasons. They see that, they can go in there with a stent and open it up, or balloon it, where it literally just balloons it, and it doesn't actually like work very well because then it just reduces in size. So they mostly stent things now, but you open it with a stent and it keeps it open. I'm honestly surprised they were able to get reperfusion on this one, because a lot of times whenever you shoot contrast and you get this goes and becomes the coronary artery bypass graft surgery, which is actually correct on here, and we call it cabbages. right? CABG, not lettuce. It's taking a vein from the leg and putting it on the heart to bypass areas that are basically like the entire artery itself has stenosed and occluded, and they can't go in and pull out all the crap that's in there. So we just have to do a bypass. Bypasses, interestingly enough, do not last very long. You have to go in and redo them every so often because veins are not made like arteries. They're kind of flimsy. They don't have that muscular tone. So you have to go in and redo them sometimes after 10 to 20 years. I didn't know that. I thought that was crazy, but I got to actually watch a cabbage be done. And like it was cool because I got to see in cath lab what started as, okay, this is EMS brought him in and he wasn't having a MI, but like he definitely needed to get to the cardiac cath lab. And so we get him on the table and we shoot the contrast, and pretty much that's what shows up is nothing. And so then that was a Friday, and then that Monday I got to go in and see the cabbage be done on him from like start to finish. It was really, really cool. They like completely stopped the heart and plug your body into a perfusion machine, and it does the flow for you, and your heart is completely still. And they give you medicine to make your heart completely still, and they put it in an ice bath, and then they do the graft of the veins, and then like they stop giving the medicine and like suck out all of the cold water, and like the heart just starts beating automatically. It's like super crazy. It was so cool to watch. So it can lead to that, and that really sucks if it leads to that. But also, like, we do have interventions like if it is that bad. A lot of times that is caused by family history or someone who has neglected to do any sort of primary care. So they don't go to the doctor ever. They're not really on top of their diet. They're not really paying attention to their body. So the biggest thing I think with ACS is that the pain occurs at rest. It doesn't go away whenever you've rested and what should be enough oxygen gets back. It pretty much has the same exact signs and symptoms of any sort of low cardiac output or perfusion, where you're going to see the fatigue, weakness, mental status change, hypotension, shortness of breath, prolonged cap refill, low urine output. The low urine output, I will say, probably will not happen with. That's a more prolonged thing because there's a lot of chemicals that have to go into that. But then it kind of shows you 0 to 100. So just know that like all the things on the 0 side go with each other. And then I would also put STEMI with that, and then in STEMI on the 100%. And then really like stable angina is stable plaque, and unstable plaque that ruptures is unstable angina or acute coronary syndrome. So like the coarser outcomes of this spectrum, either they can have the rapid deterioration, go into cardiogenic shock. That's really difficult to manage and kind of a pain in the butt. Or it's very, very long, manageable, lots of chronic medications. It also can cause, however, hypertrophy where the heart will stretch more to accommodate, and then it causes cardiomegaly, or the heart gets basically like the tissue gets really big because it's getting, those muscle fibers are getting really weak. It's called the Starling law, but think of it as a rubber band. Like, we've all like messed with rubber bands, and then we all get that like one rubber band that's like old and crusty, and like as soon as you pull it, it like snaps. That is the Starling law, where at first it stretches, it's great, but the more and more you do it, the more hard and stenosed it becomes. So you'll see that quite a bit with heart failure. And we'll move on to heart failure because I realize I'm running out of time. But so heart failure, they basically put into two categories on here, which is left-sided heart failure and right-sided heart failure. There's tons of different ways to distinguish heart failure, so just know that it's not always going to be left side and right side. But it is good to know, just because, to use it this way because of signs and symptoms. So most of the time you're going to see this from chronic hypertension and the hypertrophy, or like the cardiomegaly. And basically, whenever they said to know the flow of blood forwards and backwards, this time it actually mattered with the backwards part, because it does kind of not go backwards, but it backs up. And so if you know the backflow, you kind of can start seeing which side does what. So so if we're looking at left heart failure, the biggest difference on these is really, so I'm going to start with right-sided heart failure. I know it's backwards on the thing, but it just is easier to me. So if the right side is having a heart, and this is usually because it can't overcome the pressure, the blood, like the afterload. With right-sided heart failure, anything that's going to go back is going to go into the veins. And so you're going to see a lot of venous issues and venous insufficiencies with right-sided heart failure, and that is one of the biggest differences. So one is not more dangerous than the other, because usually you think, oh, it's left ventricle, that's the more important one. They can both be extremely deadly, especially if not taken care of. So with right heart failure, remember, backwards, it's going to be your vena cavas. So it goes up and down, right? And it doesn't start one way or another. It's both. So you can see your jugular vein, and this will get super swollen and like look like it's about to like burst. And sometimes it like even kind of pulsates. It's kind of freaky. And that's called jugular vein distension. That's never a good thing to see. I've seen it like in one patient, and I was coding them. So like, and they did not make it, unfortunately. But literally it looked like, I mean, I don't even know what to compare it to. It was like so much bigger than a straw. Like, it was like twice the size of a boba straw was how her jugular vein looked. It also mentions portal veins. Portal veins are mostly in this context, it's your liver. You can get portal hypertension, and that's kind of where this comes from, where there's that kind of pushback and pressure. So it can enlarge the liver, it can actually cause cirrhosis. And then ascites usually comes with liver issues. And it's basically extra fluid pushed into the peritoneal space, or like the fluid that surrounds the abdominal cavity. On males, it looks like they're pregnant, and it's a really weird look. On females, it looks like they're pregnant, and it's not a weird look, but on males, it looks really weird. So just know, with the liver congestion and the ascites, that is not an immediate thing or necessarily a normal thing with RHF. That usually means that it is either extremely like out of hand, or it's towards the end of that person's life. Most of the time you're going to see JVD, you're going to see the edema of the legs and feet, again, gravity, and then venous insufficiency. It can't push forward enough to get everything back up. So it just kind of seeps into the legs, into the tissue of the legs, which can very easily turn into cellulitis, which can easily turn into sepsis, which can easily turn into cardiogenic shock and multi-organ failure. And that's where I say, like, these things, if they are managed, they are not fatal, but if they're not managed, they are, unfortunately. So know that if it is a pulmonary vascular resistance, so they can't overcome, the right ventricle can't overcome the pressure that the lungs are putting out. That can be from some sort, it's usually from like some sort of pulmonary stenosis, pulmonary disease. That's when it becomes cor pulmonale. So RHF, cor pulmonale, it means right heart failure due to pulmonary vascular resistance. They have that all underlined, so I just really feel like that will be a question on the test. I could be wrong, but so usually with looking at the other side, you're going to get very different signs and symptoms. And honestly, the left heart failure, like, because it's a decreased cardiac output, you get the fatigue, weakness, mental status change, hypotension, dyspnea, difficulty breathing. You start seeing the cardiac output decreases. Where it is really bad is where it says the signs and symptoms of fluid backup. Because if you think of where the left ventricle comes, the flow of it, it's getting everything from the lungs. So the only place it can back up into is the lungs. And then you get pulmonary edema. Pulmonary edema is very scary. You can also get flash pulmonary edema, where you're not expecting it whatsoever, and all of a sudden the person is just like drowning. It's dry drowning, basically. A lot of times we'll have people who will call and be like, yeah, I've been coughing up like frothy crap the past few days. When we hear that, like, I know I'm going to be intubating someone. Like, it's not a good thing. Basically, because of that backup, and the left ventricle can't push blood out into the circulatory system, that blood and pressure backs up into the lungs, and instead of the normal oxygen flow and everything, it wets the lungs and fluid just kind of floods in. So instead of normal, I mean, the lungs are wet, but like bad wet, like not surfactant wet. It is just a lot of fluid on the lungs. You can hear it actually. It sounds like there's fluid on the lungs, there's crackles and everything. It mentions that the signs and symptoms of pulmonary edema is a cough, often with frothy, blood-tinged sputum. If you have pink froth coming out, just know that is really bad. Like, the only time that I've seen it pink and frothy is when it was that same lady with the JVD. Every time we would like squeeze the bag to give a breath, we would get pink froth shoot up the intubation tube. Usually by the time that it is pink, it is too late, unfortunately. So this is something you really like. You hear the crackles before the cough starts. If you can get the cough with the white frothy, it's a little bit, you have some time. If it's pink, it's usually pretty far advanced, and like they don't have enough oxygen. It's kind of like they've drowned at this point. And then of course, increased respiratory rate and decreased oxygen saturation, because at the alveolar level, it's just fluid. There's no air exchange going on. If you're wondering why it's frothy, it's because the air that we breathe in is getting mixed in, and it, like, the movement of it makes it frothy. You'll also see orthopnea, or shortness of breath, when they lay down. They won't let you lay them down. Literally, like, I have had someone like grab me before. Like, if someone is in respiratory distress in general, they will not, like, they cannot lay down. They will be moved forward in the tripod position. So left heart failure can be more dangerous in an acute way with pulmonary edema, but it's not necessarily more deadly than right-sided heart failure. They are both bad if we don't do things about them. But just think, with right-sided, there's a lot of places that fluid can go. It has a lot more room to move. With left-sided, it's only going to go to the lungs, because that's the only place that it has to go to. And that's why, they said, know your flow forwards and backwards, because if you can think forward and think backwards, you can kind of follow where the blood and the fluid is going. Other things that happen with that, with things backing up, is that the B-type natriuretic peptide being released. So in the ventricles, they can feel that they're not pumping hard enough, they're not strong enough. And so it releases this peptide that basically forces sodium and water. Just know, like, where sodium goes, water follows. Where water goes, sodium follows. It's interchangeable. Just know that they go together. So it's going to release that peptide, and that peptide is supposed to help increase the amount of sodium that the kidneys pee out, because water follows sodium. Unfortunately, like, where it says frantically generally means, like, it's not doing too well. It doesn't do enough. And it doesn't. So when you have that BNP, that high BNP, it's just showing that there's enough of a overload of fluid that one of the ventricles is not being able to pump like it should. It's reduced cardiac output. The issue with this too is if it's a decreased cardiac output, just because it's backed up elsewhere, our kidneys don't realize that. And so when you get into the RAS system, where the renin is activated once the blood pressure to the kidneys gets down low enough that it triggers sensors, it's going to activate the RAS system to increase the blood pressure when the blood pressure was the issue to begin with. So that's where your ACE inhibitors, your angiotensin I think they're ARDs inhibitors, angiotensin, renin, I can't remember. ARDs are a little stronger than ACEs, and sometimes they can really help the kidney, so you may see them used in kidney disease as well. But both of these are going to work on the kidneys and the renin and angiotensin system in the kidneys, because basically your body can't realize the difference between like when to go into fight or flight and when to not go into fight or flight. It's just going to respond. So we tried to stop the RAS system, and then to get that fluid off, kind of going with what the BNP is trying to do, we can give diuretics, which is furosemide or Lasix. Lasix is the brand name, furosemide, the generic. That's the most common you'll see. They force, on a bigger scale, they force sodium to be released more by the kidneys. So you're going to pee more, right? Because water follows sodium. This is also where you're going to have issues with potassium. Every single patient that is taking a diuretic should be taking potassium as well, because it also spills potassium. It pulls the potassium and water follows. So you can actually get hypokalemia really easy in your congestive heart failure patients, where you don't really see that one as much. But when you do, it's also just as dangerous. So BNP, so like ANP, I didn't even know that was a thing, but like we don't measure atrial peptides, just the ventricles, or the B type. If it's high, it's an indication, because it's kind of like they talk about the positive and negative feedback loops. Basically, like, it's a loop that once it starts going, until it's fixed, it's just going to keep releasing. So if you're in severe heart failure and you don't do anything about it, you're going to see this like ridiculously high BNP, because it just keeps collecting and collecting and collecting and trying to get the kidneys to do things. But also know that sometimes the backup can be into the kidneys and can kill the kidneys, just like it can the liver. So it gives a clinical example. A healthy man's BNP is 50, which usually it's not even that high. Mild heart failure, they say, is 130. I really thought that 400 was heart failure, but I could be wrong. I don't remember. An example of someone in severe heart failure is like 1,000. The highest that I have personally seen was a woman who has a history of CHF and hypertension, and doesn't have a cardiologist, who was having shortness of breath for the previous 3 days, finally came in, had acute renal failure or acute kidney failure, and had a BNP of 28,240. And she was walking and talking like totally fine. So the heart can be very fragile and it can be very, very resilient. It just kind of like, that's where that chronic versus acute kind of comes in. When it's a long-term chronic, the body kind of builds those defenses. Dialysis patients, like, they may have these ridiculously high potassium levels, and they're like totally fine. Whereas like someone who has normal kidney function can barely go outside of that range because their body's just not used to it. The body does get used to things, which is cool. It's adaptation, survival, but also like you can just see some really crazy crap out there. So just be prepared for that because COVID made it worse. So that's the whole thing with BNP. Remember, BNP is specific to heart failure, while troponin is specific to heart attack or myocardial infarction. So then the last part of it, the cardiogenic shock. I will probably make a separate video on that because there's a lot of things that are incorrect. Not incorrect, just not explained well. But it is a really interesting thing to deal with and to look at. So I'll probably make a different video of that, but it's not on the test, so thank heavens for that. So that's kind of all that's here. If you have any questions, feel free to, you can email me, you can DM me on, I keep going to say Messenger, on GroupMe, or, throw it out there in the GroupMe because you're probably not the only one who has the question. So just let me know, and hopefully this was helpful. Thanks, guys.